we're a little bit off schedule, but we'll take a few minutes for questions. I'll start with you, Anil. How does one interpret the resistive index, which is often reported on transient ultrasound and Dopplers? Does this help to distinguish delayed graft function from rejection?
No. It's a simple answer. It tells you that perfusion is abnormal, but doesn't distinguish delayed graft, doesn't distinguish ATN from rejection necessarily. It is really more if it is normal that it may help you think about a non-parenchymal cause. But again, it is operator dependent. So you have to take it as part of the overall information that you're getting.
And Anil, do you want to comment on when the resistive index is normal to low in the case of delayed graft function when you would suspect it to be high?
Yeah, so that's an important question. And don't miss this clue. If you see a low resistive index, it might indicate there's renal artery stenosis. And so the input there is because the inflow is lower. And so the resistive index is lower than you might think. And, we've all done this. We've all missed that and thought, oh, that's normal. But think about it in the right setting and confirm it with imaging and Doppler.
And we had just a recent case where we had a normal resistive index, and this what triggered us to really do MRA and found a renal artery stenosis. Thank you, Anil.
The other consideration, obviously, is this renal artery pseudoaneurysm as well. So anything sort of decreasing renal artery blood flow would lead to that.
Melissa, a question for you. Cytotoxic cross-match is not always done. Isn't there a concern for non-HLA antibody or IgM-mediated rejection that may not be picked up on flow cross-match?
Yeah, that's always the theoretical concern. I think that was more so a concern in the past when our patients were getting a lot more blood transfusions, and if they were getting whole blood transfusions. These days, many places use leukoreduced PRBC to reduce the sensitization based on the platelets and the white blood cells that might be in whole blood. But there is obviously the consideration that the CDC cross-match positivity might be due to IgM non-HLA, which wouldn't cause an increased risk of rejection. And in those cases, if you see that happens, then the important thing to do is as a clinician, just review whether or not there has been potentially any sensitizing events that have occurred within the last 4 weeks.
On this topic, if CDC and the flow cross-match measuring the same antigen, so why is the CDC cross-match as an absolute contraindication, not the flow?
Yeah, that is really a measure of the sensitivity. So the CDC assay is less sensitive than the flow cross-match. So in general, a flow cross-match could detect much lower levels of antibody, whereas with a positive CDC, then you know that the alloantibody burden is so high that your risk of hyperacute rejection is very high. The other consideration is that there's complement-mediated cytotoxicity or graft destruction versus the other pathogenesis, which is antibody-dependent cellular cytotoxicity. And if it's complement-mediated, in those cases, there's more of a concern, again, of hyperacute rejection.
Very good. So I think we'll stop here to give the attendees enough time for a break before we start again at 1:40 with the donor evaluation. Thank you all for joining us. It was a great session. Thank you.